Okay, looks like we're recording. And the reason we want to record is because I'm trying to do a whole series of talks, and maybe some of you have already seen some of them, I hope. They're pretty popular, and I put them all on my website, which of course is dcurology.net. Going to try to have that list get longer and longer here, and this not only helps my patients. These are tools that I use to go from a conversation. Maybe I've just told someone they have prostate cancer in my office. Well, if that's any of you out there, then you know that I generally say, next step, please go to my website and let's do a lot of learning, because learning is the key to feeling comfortable about things once you've been told you have prostate cancer. So if you have to leave, or if you have friends or anyone else that might be helped by watching this talk, which I've given many, many times. I was thinking about it the other day. I've probably given this talk 4,000 times in my career. And that is the talk of what do we do now that you've been told you have prostate cancer? And I want to make something clear from the outset. We're talking about localized prostate cancer, meaning we're talking about prostate cancer that, at least to the best of our ability, has not spread. Okay. If you we won't go into too much detail. How do we know you haven't spread? And we do our best efforts. These days, I mostly just do a CAT scan. Some people are doing a newer scan called a PSMA scan. Radiation therapists do that. Bone scan is a part of this as well. I don't use it that much. But if we say, okay, there's prostate cancer there, and if we say, to the best of our ability, we don't see any spread, then we're going to call that localized. It's not a guarantee, but that's what we're talking about today. Metastatic prostate cancer, they call that advanced prostate cancer, is a whole other discussion in every way, shape, and form. And I'm not really going to talk about it today. That's more of a medical issue. We use things like hormone therapy, and that could be a whole other talk that I give someday. But this is the most common one that I give, because most commonly cancer is localized when you have prostate cancer. So let's sort of dive in here. Looks like I have to use this. Okay. Now this flow chart, again, don't know if anyone out there has actually been in my office, which is where I am right now, and been in a situation where, we have already gone through the whole process really on this flow chart of step number one. Do we need to do a biopsy? This is a whole other talk, by the way, and it is very much represented by another talk on my website about prostate cancer screening, how I do it. So I certainly invite you to go watch that talk. If we're saying that if the result of that biopsy shows cancer, which is always scary, everyone who usually doesn't know that much about prostate cancer at the time. So it's all the usual things of, oh my God, do I have to get my affairs in order? There's usually just complete misunderstandings about prostate cancer, all the way from, I heard it was nothing to worry about, you never have to worry about it, it doesn't harm anybody, which isn't true, to, oh, they're thinking it's just as bad as things like pancreatic cancer, brain cancer, things like that. So that's what we're going to talk about in a minute when we talk about risk stratification. That's the bottom line, is if you're told you have prostate cancer, the whole idea is you need to understand one main thing with prostate cancer. Okay. And first of all, let's just talk about what cancer is. I always start with that. Whenever I ask people what is cancer, and we would all assume we could answer that, hardly anyone can ever answer that. So I'll just throw it out there right now. Let's give this talk as if you're my patient. We've already struggled over whether to do a biopsy. In my practice, I've already waited for a PSA that's very suspicious. So I already know it's probably cancer that has to be treated if it's positive. And now we're sitting down, and step one is to educate. So we start with, what is cancer? And what is cancer? Cancer is, and that's not on the slide here, so I'm just free associating here. Our bodies are made up of cells, and those are the basic building blocks of things here. And it's an amazing process by which we're conceived, and then we're a ball of cells where they're all the same. And then cells are given sort of job descriptions. They're given jobs, and those are dictated by our genes. This cell is supposed to be an eye cell, and this cell is supposed to be a liver cell, and this cell is supposed to be a prostate cell. And they're supposed to go through a period of maturation, but then there's just supposed to be a factory worker that does a single job, and that's what they do. What cancer is using the same messaging that figures that stuff out, those genes, and all of us, all mammals, almost everything, have genes within us that are, I consider them self-destruct mechanisms. Genes that when turned on, immediately switch over to say, we're going to use your own processes against you. Your cells know how to grow. They're not supposed to, but we're going to tell those cells that all they're supposed to do is now grow. Cells know how to invade, believe it or not. When we're in our mothers, we have to build placentas that invade their uterus, actually. So all that mechanism is there to invade, and cancer cells get that instruction to invade. They are told to grow and invade. And it's that invasion, and it's the growth that gets them near something like a blood vessel or a lymph channel, such that if it's invaded, it can spread. That's how cancer spreads. So the enemy is spread. Now, when you say I have cancer, that doesn't mean anything, because you have to know what type of cell went crazy. I usually use this analogy of a movie. These days, I'm getting so old, most people haven't watched it, but it's a movie with Will Smith called I Am Legend. It's a zombie movie. And basically, if anyone's watched that movie, they know there's the zombies just kind of only know two things: stay out of the light and eat people. And some of them are absolutely crazy and aggressive, and some of them hang around in the background. That's how cancer cells are. Well, the thing about some cancers always have the crazy ones. We can think of those where if you're told you have that cancer, you're not doing well. Pancreatic cancer comes to mind. But things like prostate cancer and breast cancer, the problem is that the cells that can start up and be cancerous, meaning having those two things, grow and divide, they live under an enormous spectrum. So sometimes they just sit there and hardly do anything, and sometimes they're horribly aggressive. And this is what you need to learn about. What do I have? What dog am I dealing with? Is it a pit bull or is it a poodle? I always say. So that's the first step of understanding what to do. So when I tell people, let's start getting educated, notice that it starts with this. Let's talk about your case. That's called risk stratification. We'll get there in a moment. And then the number one thing, and I will not move on in discussing things with patients until we feel very comfortable with each of these individual decisions, would be, do I really need to be treated? And to some, that's insane. They're thinking, of course I have to be treated. I have cancer. But we know now that is not at all true for all prostate cancers. Very true for some, not true for all. So we're going to talk about that. So let's sort of dive in there. And I also want to notice, look how much I've been talking already, and I have not talked about any treatments. And this flow chart, which all my patients are told to find on my website, and it's very much on my website, this flow chart starts with all these things before we talk about any treatments. And so that's sort of the first level of things, is understand the problem and understand your particular case. Then we'll move on to treatment. So let's do that in today's talk. Quick summary of what we're going to cover today, and it's not going to be everything, unfortunately. I'm just going to try to focus in on, you've been told you have prostate cancer. Let's talk about, do you need to be treated? And if so, what's the best treatment for you? So the first thing is to understand your case. That means risk stratification. And look at the risk categories that I make. This is one that I talk about I made this up. I like to call certain cases no risk, so the patients understand there's no reason for you to worry about this. There's no reason to be treated. And this is what you tend to find if you biopsy people too early. And then there'll be things low risk, moderate risk, high risk. And that's the first thing we're going to do. I'm usually sitting, I can't actually see my picture here right now, but there's an office plotter on my desk here. And I usually talk about, where are you on this scale here? So we'll talk a bit about the things that go into determining risk stratification. And the next thing is, every patient of mine needs to say and ask the question, am I a candidate for active surveillance? Meaning, active surveillance means we're not going to initially treat you. So we'll talk about that, because everyone should understand who does do that, and then who is that not appropriate for? What does it mean? Who's a good candidate, and how do we do it? And then we'll dive into treatments after that. And because after that, in the flow chart, you would get a sense of, am I going to be treated or not? There's a whole bevy of treatments out there that generally sound really good to patients, because they generally are designed to be less aggressive, limit side effects, but it's at the expense of cure rate. And usually patients are not aware that it's at the expense of cure rate. But sometimes that's entirely acceptable to choose a lower cure rate treatment. So we'll go over those a bit. And then if the idea is my case, because of the risk stratification, is not appropriate for those lower cure rate things, or some patients just are not comfortable with the paradigm of choosing something with a lower cure rate, then we're generally what I call going back on the rails, and we're discussing either surgery or radiation. Radiation not only comes in different flavors in the lower cure rate category, it comes in different flavors and different approaches in the higher dose categories. Surgery these days is basically robotic surgery. We can talk a little bit about the history of that. I've been doing that since 2004, so I certainly remember the days. I'm rewriting my website right now, so it's a trip down memory lane where I'm talking about other ways to do surgery. But these days, robotic surgery rules the day. And then we'll talk about the pros and cons and the side effects, really, of both approaches. So let's start diving in, and let's start with risk stratification. Again, understanding huge spectrum of activity with prostate cancer. It's really the same discussion as with breast cancer. We overdiagnose prostate cancer because we have a screening program. We overdiagnose, well, we have a screening program and we have a fee-for-service health system. And we overdiagnose breast cancer as well because we have aggressive screening. The more testing we do, the more expensive the testing there is. Generally, the more we overuse it, to be honest with you. So these are the things, if someone's told that they have prostate cancer, I call it the salad bowl. These are all the things that go into determining where are you in terms of risk. The problem with looking on the internet is it tends to stratify these things that I'm talking about as, there's no as single things. So for instance, the Gleason score, or the Gleason group, is the grade of the cancer. That's what dog are you dealing with? Is it a lower grade cancer such that it sits there, or a higher grade? Now, these days, especially because of the overusage of MRI, it only sees high grade things. There's this message out there that lower grade cancers are never a problem. They're more often not a problem. But again, it's only one factor that you throw into the salad bowl of the ones that I've mentioned here to determine what is your risk stratification. So the number one thing to think about when, and I hate to say it, but car salesmen size you up when you walk in the door, and doctors are sizing you up when you walk in the door, because we're trying to help you. We have to do that. And the age and the health status of the patient is really huge. Age is not everything. We talk about it in our presidential election, of course, but it has more to do. There's people that are older that aren't aging well, and then there's people that are older that are fantastically aging. So it's not an absolute cutoff of age, but it is an important consideration, because at the end of the day, what we're trying to do with prostate cancer treatment at the end of the day is we're trying to make it so that that problem, prostate cancer, does not shorten your lifespan. So if you don't have much lifespan, and we just have to be honest about what that lifespan would be, affected by age and health status, then we should be thinking the older you are, or the more infirm you are, the more aggressive the cancer has to be to shorten your lifespan, if not aggressively treated. So really, that's the number one thing that we're going to think about when we're thinking, where are we at? And remember, risk stratification determines not only do you have to be treated or not, but if you are going to get treated, it very much dictates what treatments are appropriate for you. And that's sometimes very much lost on patients, where they get subjected to marketing and they rush to treatments that sound great, not understanding first their case, and therefore what treatments are appropriate for their case. So age and health status goes in the salad bowl. Gleason score, or the group, that of course is very, very important, but it's not to say, and the scores, let's call it 1, 2, 3, or 4, or Gleason score 6, or 3 plus 4, or 4 plus 3, or beyond. It's not to say that all Gleason 6s are okay, and that's a dangerous message that's out there, or Gleason 3 plus 4 is okay. I have plenty of people that are metastatic with those scores. It's just something that goes in the bowl that's going to say it's one variable. Here's one that most people don't really pay attention to, because there aren't a lot of papers that talk about it much, but this is very much something that I pay attention to. If someone has a prostate biopsy, you'll generally get a schematic, and we commonly will split the prostate into 12 zones. So let's call it 12 needles. I happen to do 18. But it's not only important what your Gleason score is, but of course it's important how many needles out of the 12 are positive. It's kind of intuitive, but if you have 12 needles positive, obviously that cancer is showing it wants to grow, and we haven't caught it early. So that's a higher risk situation. If you and likewise, if you have one needle, that generally is saying, maybe, how do we know that the cancer has grown? Well, it gets even more granular than that on a path report, on a pathology report. The pathologist will report not only how many needles are positive, but they will also report of the little piece of tissue. And today was biopsy. I do something called saturation biopsy. So I've seen many of these pieces of tissue today. Of the little worm of tissue, what percentage of that had cancer in it? So obviously, if it was just one gland, again, is that really growing? If it's the whole core, then you know there's a lot of cancer. So volume of cancer and number of needles positive are a very big determinant in this salad bowl, and it tends to get lost on people. PSA trend. So this is a very important thing. If you go back and you have looked at any lectures I've done on how I do prostate cancer screening, it's very much centered on the PSA trend. It is not centered on fixed numbers. It's centered on a trend. So if I have a person whose PSA is 8, but it's basically been bouncing around wildly, up and down, all over the place, that's not very suspicious to me. And if I have a patient whose PSA is 6, but it started at 0.8, and then it was 2.3, and then it was 4.7, and then it was 6, that is way more suspicious than that patient whose PSA is 8 or 9 and doesn't have a suspicious trend. That is extremely difficult to sort of bucket that in a paper. So there tends to be these very old papers fomented by Johns Hopkins that talk about PSA, for instance, between 4 and 10, and 10 to 20, and greater than 20. And it just doesn't tell the whole story at all. And it's too fluid to write an essay. There's too many trends to discuss. So that tends to be also something that's hard to teach yourself about on the internet. But PSA trend is extremely important. It to me will trump the Gleason score, because if I see a person with a very suspicious PSA trend, but a biopsy with a low Gleason score, I'm commonly thinking that my needles have not found the real cancer that is responsible for that trend. And so those are the things I'm going to use to determine these risk stratifications. I'll just point out that there is a huge business out there of what I call genetic risk stratification tests. And these are the 3 on the market that are the most popular. They're very expensive, sometimes insurance-based, sometimes it doesn't. And in my practice, they just don't have any role, frankly. And that's because of the fact that I am somebody who is going to only biopsy you once you have a very suspicious PSA trend. So that's how I do it. I don't need the genetic test to know that that person's cancer is growing, because I've already demonstrated that. There are other practices, and I would say most practices, that once your PSA is abnormal, they will screen you with an MRI, which tends to overcall things. And then they'll do biopsies that they otherwise wouldn't do, and they won't know what to do with the information. And that's where they're looking for more information to help them. And those practices tend to use these genetic risk stratification tests. So I throw it in there because other practices with different biopsy patterns than me will use this as part of the salad bowl too, but I won't. And so here we're going to break it into these categories. Okay. So once you have the risk stratification, and once you've gone on the website and you clicked on common problems on my site, and you've read my essay on prostate cancer, now you know about Gleason scores, you know about PSA trends, you know the difference between a high risk situation and a low risk situation. And so at this point, the patient is educated, and now they're ready to make a decision. Okay. Let me see if I probably would have wanted to, and that means they're here. And then once they know their risk stratification, that means they're ready to answer this question: is treatment indicated? In other words, am I a candidate for active surveillance? We'll talk about that in a moment. Or should I be treated? Okay. Notice that no risk, and this actually this is actually a little bit confusing, because it says, is treatment indicated? And the answer is no. But if it's a no risk case, it's automatically no, and it's active surveillance. Notice even in a low risk category, low risk might be an older patient. Low risk might be a patient with Gleason 6, sometimes 3+4, but not much. If I see Gleason 6 and lots of it, or a very suspicious PSA trend, I'm not going to consider them for active surveillance. So notice that some low risk patients do consider treatment, and some low risk patients, we say maybe you're good for active surveillance. So it's the low risk category that is, sometimes the patient has to decide what to do. That's sort of the area where we're not sure. But if we know from that salad bowl that you're medium or high risk, a little bit of Gleason 4+3, a patient who's 52 years old, somebody that's got a PSA of 15, regardless of their Gleason score, they're at least going to be medium and sometimes high risk. And those are the people, okay, that are going to have to say, I need to choose a treatment that emphasizes cure rate. We're going to talk about that. And you might be wondering, that's ridiculous. Why wouldn't you do that? We'll get to that in a minute. But now we're ready to go back and talk about active surveillance. So this is the key concept, the concept that what is active surveillance? That's what number one is. It is the concept that more evidence of significance, meaning this idea that some cancers, prostate cancers, are insignificant and therefore shouldn't be treated. It took us 25 years to understand that if that salad bowl isn't telling us enough things to say that you definitely have significant cancer, what active surveillance is saying, we're just going to watch it for a while and we're going to see what happens. We're going to see if we biopsy you again, if more cancer is present, it means it's growing. We're going to look for evidence of growth. We're going to see if the PSA rises. That's what active surveillance is. Everybody does it a little bit differently. In essence, I'm going to do a PSA every 3 months. That works very well in my practice because remember, if you've had a biopsy, we've already seen your PSA rise, and I'm looking for it to level out to know that I'm okay here. If it keeps going up, you might fail active surveillance. And in fact, a lot of my patients, if they just see me for elevated PSA, I will have many patients where I'll talk to them about a concept called active surveillance without a biopsy, meaning I'm telling them that you could have a little low-grade cancer, but I'm not going to treat it unless it gets more suspicious. So I guess in a nutshell, what I do to screen patients is I do active surveillance without a biopsy. And then at a point where a patient would have failed active surveillance, that's when I do their first biopsy. So that's an aside. So, but generally it's a PSA every 3 months. And then I always rebiopsy a patient at 1 year. And why? Again, we're looking for evidence of growth. So anyone who's in active surveillance would have started with a very low risk pathology report, not much cancer, low grade. And that would have typically in my practice been a standard biopsy done in the office. Well, what I'm going to do at 1 year is I'm going to do a much more sensitive biopsy called a saturation biopsy. And I'm also going to use, that's when I use MRI. That's what it's supposed to really be used for, not as a primary screening test, but I'm going to use an MRI to see if there's a lesion there that I can do another fancy biopsy called an MRI fusion biopsy. And I do them both at the same time, as I did on a few patients today, to say, we are going to do the best biopsies we can possibly do, and there's almost no way we're going to miss anything. And if you had cancer a year ago and it really isn't doing anything to you, then it should still not be much there. But at 1 year, it's really time to know, is it growing or not? Because after that point, we may never biopsy you again. We may just follow you with PSA. So really when I'm doing active surveillance, because I'm somebody that biopsies with several PSA rises in the first place, I'm thinking there's no evidence of growth here. And most of the patients that I say do active surveillance are patients that really never end up getting treated. It's not a delaying tactic. It's saying, I'm thinking you're not going to get treated, but I will treat you if I'm wrong. It's not just, well, we biopsied you really early, so now we're going to wait and then treat you later. So you can kind of tell how aggressively people biopsy somebody by their treatment rate in their active surveillance arm. If they're very discriminatory with who they biopsy, and then they do active surveillance, they tend not to treat many patients. If they biopsy people very early in the game, they simply haven't let it present itself. So then many series of active surveillance will have like a 50% treatment rate if they biopsy them too early. So in my case, if you're told to do active surveillance, I would say it's about a 15 to 20% treatment rate, meaning I found more cancer at 1 year, or the PSA kept climbing, in which case I biopsied them earlier than 1 year. And we've already talked about the role of MRI. Again, I don't use it as a primary screening test, but I do use it as part of active surveillance. And I do use it in a patient who's already had one biopsy, and now their PSA just keeps climbing. I have to do something. And what I'm really going to do is a saturation biopsy there, but I'm always going to do an MRI at that point too, to see if I can do an MRI fusion biopsy. And then really, we know this is the right thing to do. You can imagine how controversial this was in the beginning when people were being told to do active surveillance. They used to get biopsies every 3 months because we just didn't know. And there can be a fair amount of anxiety to this. But I believe my goal is to teach patients enough and to teach them so much that they're not going to choose to be treated just because they're anxious. That's not a good reason to be treated. That's a good reason for more education. So that's how I'm going to view that. So there were many days where we would say, well, if you're too anxious to do it, we'll go ahead and treat you. That's just not, I think that's a cop-out for lack of education. In the original series of active surveillance, we weren't as discriminatory as we are now. There was the concept of waiting too late. Europe didn't treat prostate cancer, and they kind of showed that they were waiting too late. But those are extremes, and I don't see that. I actually don't ever remember a case of active surveillance where by the time we said, let's do something, it was too late. It doesn't tend to work like that. And one more concept of active surveillance is that you have this low-grade cancer, but there's always a chance it can transform into a higher grade cancer. And so at least getting PSAs every 3 months will make sure that you're okay and you don't have to be anxious that you waited too late. And I'm going to come back to that flow chart a few times as we get there. But just to remind everybody, so now we're going to, so if we're going to do active surveillance, we're just going to say, I'll see you in 3 months. We'll biopsy you at 1 year. But if we say no, there's just a little too much cancer there. And I'm not that comfortable. When people are in the Gleason 3+4 category, for instance, those patients usually end up getting treated in active surveillance, but I still might follow them. So let's talk about these treatments with lesser cure rates. And I don't know how a more polite way to put it than that, but these are them. And some are very popular, some are not very popular. Now we're here in Washington, D.C., and the most popular treatment, and Sean Collins at Georgetown, my friend, might take might take this to heart a little bit, but generally CyberKnife radiation. This is the brand of it's super focused radiation, CyberKnife. Maybe people have heard of something called Gamma Knife. If you have a brain tumor, they will do very focused radiation on that called Gamma Knife. And CyberKnife is very similar, super focused radiation to the prostate, which on paper sounds fantastic because we'll talk later about the side effects of radiation, and generally they are from the effects of radiation on the neighboring organs, the bowel and the bladder. So if it's super focused, you're going to limit that exposure to the bowel and the bladder and maybe the nerves and the blood vessels that affect erections. But that is the problem, that's the benefit, but it's also the problem of CyberKnife. Without an overlap over the edges, it means they're going to give you treatment in 5 days with CyberKnife. It's great. And I think I blew this out a little bit. Yeah, I go over this a little bit more. So let's not do it too much. Let's just go over the list here and I'll go through each one. There's CyberKnife radiation. We are going to talk about that because I very much advocate that in the proper cases. There's brachytherapy or seed implantation. Everyone seems to have a family member that's had that done. And that's because it used to be wildly popular. Back when I first came out of training, the chairman of Intel had seeds and he wrote a big book about it. And so had a lot of popularity. It was the initial attempt at being minimally invasive and it sounded great. Instead of shooting beam radiation, which was not focused back then, it was a way to put these little pellets in your prostate in an array that didn't penetrate too much with the hope that there wasn't too much overlap. And the problem is when people, and this is one of the rare situations back when there really were head-to-head studies, And back then it was open surgery. It wasn't robotic surgery. So it wasn't quite as good. Surgery wasn't quite as good. But even against open surgery, seeds had way more side effects. It did not spare erections the way that it was supposed to. It had a lot of irritative voiding symptoms, and people could be very miserable with that. And it simply didn't cure people nearly as well as surgery did back then. We're talking here about the early 2000s. It would say it's only good for Gleason score 6. Well, in the early 2000s, we didn't know that most of those patients didn't have a disease that grew. So everything looked good in Gleason 6 because 80% of the patients being biopsied back then didn't need to be treated. So the cure rate of seeds is abysmal, and they tend to migrate. And so really, there are a few people that still do it around. An old friend, Greg Sibley, does it in Northern Virginia still. But other than that, I don't advocate that. To me, CyberKnife would be the replacement for that. Cryotherapy is freezing your prostate. We'll get into that. I do that. That's for certain patients. That's not sort of the hammer on a tool belt. You'll know the right case for that when you see it. This is another technology that some people are doing. It hasn't really caught on. It's something that patients would find on the internet. There are a lot of complications from this, way more than the other things. It tends to make it very hard to urinate. So to me, there's not a lot going for it. There's no real advantage to it. It was being offered for a long time here on a cash pay model. Before it was FDA approved, people would fly to the Cayman Islands to do it. But I looked into it, and I don't advocate it for my patients. And finally, this was very popular for a while, the concept of focal therapies, maybe just freeze a certain spot or cook with HIFU a certain spot to minimize side effects. But these days, really, anyone that's a candidate for that kind of treatment, which would have been a tiny little bit of low-grade cancer, maybe by now, because you're learning, you know that patient should just have active surveillance. So I do not advocate focal therapies. I advocate active surveillance and then just doing real therapy, only if you need it. I don't advocate HIFU because of its complications. So these are some extra bullet points so you can learn about these. And again, I'll try to talk about who's a good candidate. Again, these in that category of lesser cure rate are the less aggressive radiation offerings. Again, there's CyberKnife. And, interestingly, only Georgetown has this in Washington, D.C. They're the only ones that have it. I suspect it's because other research institutions, Hopkins, and now Sibley is run by Hopkins, Suburban is run by Hopkins. I know it's very lucrative, but I know it's not really been adopted, perhaps just because it doesn't participate in the same clinical trials that the other radiation trials do. And radiation is an extremely results-oriented, really high-quality study-oriented field, which generally will have 29 sites that are contributing patients, and their conclusions are very strong. And the CyberKnife is just out there, really. It doesn't really have that same type of clinical research associated with it. Perhaps that's why it's not there, but it is an excellent, excellent tool for the right patient, which is a low-risk patient. All of these, to me, are for lower-risk patients, except that when I talk about cryotherapy. Why do people love CyberKnife? Sounds cool. It makes it sound like a robot, like robotic surgery. But the main thing is, instead of having 7 to 10 weeks of treatments, it's only 5 treatments because it's a lot of radiation in 5 blasts because it's focused. It does not provide overlap, though. That's to reduce side effects. And I say likely lower cure rates because intuitively it's obvious that it would have lower cure rates, but there's really no head-to-head comparisons. And for me, it's for lower risk cases. So when I have that person not that comfortable doing active surveillance, I think it's just a matter of time till they get treated. To me, I call this active surveillance plus. Even maybe an older patient, this is not something I would be advocating for a 52-year-old man. We'll talk about that later, but radiation tends to burn bridges. We've already talked about seed implantation. Important to know about it because you'll have some family member that has had this, because this used to be very popular. More popular in less urban areas now where maybe it's not all the technologies are offered, or there isn't a high volume robotic surgeon that's doing elaborate surgery. So, it's still maybe offered there. But this is a single session, and people love that. It's an outpatient procedure. It doesn't really hurt. This was the original minimally invasive approach, period. And that's why it was so popular. And these are the downsides. To me, CyberKnife is the new seeds. I haven't done it in a long time. Used to do it plenty. I just don't think there's anything advocating for it. It's got lesser cure rate and just as many side effects or worse than surgery. So that doesn't really follow the rubric of what you're looking for. And then the other ones that were on my list are here. Prostate cryotherapy, I'm actually a big fan of. I've done many of those. Who's the right person for that? Doesn't have to be a low risk patient. It is perfect for low risk patients. I am the first to tell patients it will not have the same cure rate as more aggressive treatments. However, the great thing about cryotherapy is if you recur, it can be repeated. There aren't a lot of downsides, but it does have the same problem with erectile dysfunction that surgery does. We'll talk about that. It is a single treatment. It's not a big deal. It's got very rare side effects. But recurrence is not uncommon. But it helps you urinate. It basically freezes your prostate. It doesn't completely go away. The shell of it goes away, but the inside of it opens up. And so who's the perfect candidate for cryotherapy? Older man, can't urinate well. That usually, as a person that might have radiation is going to make that man miserable because he can't urinate well. To me, cryotherapy becomes an excellent option for those patients. So even a higher risk patient, maybe he's 82, has Gleason 9. You don't really want to do all these other things. You just want to push the disease state back several years. You can always do it again. That's a perfect situation for cryotherapy. So you can see that's not a typical, 56-year-old, I'm 56, high PSA, localized, that this is not going to be a good solution for that person because you don't want to recur. Why would you subject yourself to something like that with lesser cure rate if you're going to go through the same problems with erectile dysfunction? So you can see that CyberKnife in my practice is for specific patients, and cryotherapy would be for very specific patients. HIFU for me is for no patients because, again, I just don't think it has a lot going for it, to be honest with you. But it is a very easy thing to do. It's a very short learning curve. Many doctors haven't been trained on cryotherapy, so HIFU is a lot easier to do. And so again, if this is all about my practice. So if your urologist, doesn't have access to cryotherapy, isn't a high volume robotic surgeon, doesn't have Sean Collins at Georgetown to send you to talk about CyberKnife, well, they may need to resort to what they do have and have done well, and that might be HIFU. So I'm not trying to say in all circumstances it's horrible, just explaining why I don't tend to do, because these two are my mainstays in the lesser treatment department. So now, let's say we say you're moderate to high risk. I'm telling you at that point, you're not a good candidate for those lesser. You need to prioritize cure. And again, this concept of you don't just pick a treatment because you see it on the side of a bus and it sounds good. You don't pick a treatment because a friend did it. You pick a treatment because you completely understand your problem. You completely understand the problem of cancer, prostate cancer, and then your particular case to then understand what is the appropriate menu you should be choosing from. And that's a different menu in terms of moderate and high risk. So we'll talk about that a little bit right now. Let me make sure that's not on the next slide yet. Moderate risk patient would be, let's call them a Gleason 3+4, but with a lot of cancer. At least maybe the PSA is 12 or 9. Why is that differentiation so important? Well, moderate risk, and by the way, if you're low risk, it's perfectly reasonable to say, I'm not comfortable choosing a lesser cure rate option. So it's never, if you're low risk, you should choose one of those lesser cure rate options. It's their options for you, but you have to go into them understanding those limitations. And too few people do that. They think they sound good and they don't know what questions to ask. So again, that's part of education. And most people, when they understand that, they generally are uncomfortable with that. And they tend to shift back over to surgery and radiation as the things with the highest cure rates. So anyone can have a surgery, by the way. So low can have it because they like the effects, the pros that I'm going to read to you. Certain personality types, that's just what matches them. Moderate risk is certainly needs to get a higher cure rate treatment, so that would make a lot of sense. And I'm going to talk about high risk, in my opinion. I have a strong opinion that you should have surgery. Okay, so I'll talk about that a little bit when I go back to the flow chart. But let's just talk about the quick pros and cons of if then someone says, okay, I need to make a leaning between surgery and radiation. So these are, we already talked about how I don't really call it robotic prostatectomy anymore. Notice I called it radical prostatectomy, even though it's not a very radical operation anymore. It used to be very radical. We used to think you'd have to, remove all the tissues and everything around there. And we really learned that was a bit of a mistake. And now it's a very delicate operation done robotic. So I just call it surgery, really. I don't really get questions anymore about what is robotic surgery, but we'll talk about it slightly. The main advantage of surgery is the acuity, meaning nothing's going to get dragged out. You're going to have a surgery date. You're going to have that surgery. You're going to get it behind you. You're going to feel like nothing happened 2 weeks later. You're going to get through that. And then all the side effects that come with it, which are you'll lose your erections at first. You'll leak at first. That's what comes. There's nothing else hidden. Basically, aside from very rare surgical complications, it's erectile problems, incontinence problems, but they all are going to start the day of surgery. Everything starts the day of surgery. There are patients, frankly, that's just how they would do it. I'm a neat desk person. I'm a list person. I'm an anal person. And for me, I have a problem that is only one way. It's just get it over with. And if I'm going to have to deal with something, I want to deal with it right now. I want to get it off my mind. I don't want to dwell on it and lose sleep over it. That's a personality. Doesn't mean it's your personality. But I do talk about that a lot in these talks, is to explain you're not going to figure out the right answer. I believe surgery is the right answer in very high risk cases. But other than that, there is no right answer. I'm educated. I understand the pros and cons. And this is what feels right to me. That's as scientific as that. This is what feels right to me. So for some people, surgery is the only way to go. They want that acuity up front. They want to know if they're cured, meaning the PSA is going to tell you you're cured. It's that simple. If the PSA is 0, you're basically cured, and we'll look for recurrence. So that's in a nutshell in developing a leaning between these two. Those are the pros. But in some people, they can't handle the acuity. That acuity is not matching their personality type. The personality type of, I'll worry about tomorrow. I only worry about today. I don't want everything coming at me all at once. I'd rather take daily treatments for 7 to 9 weeks. One of the downsides of radiation is it has early side effects, mid-time side effects, and late side effects. So the personality type that's perfect for that is someone that says, I live in the day. I'm not going to worry about it. I'll worry about what happens later. They're probably happier people, and they probably have lower blood pressure. But personality type really should play a role in this. And if there's any question as to whether radiation might be a possibility, that person should go and get a speech like this from an excellent radiation therapist in town. Obviously, there's some patients where it's going to make more sense to do radiation. Sometimes you just have a hostile abdomen, we call it, where it's just too risky to try to do surgery there. We're going to injure something. If you have a lot of comorbidities, it probably makes sense to avoid surgery. And there tends to be a bit of, the older you are, the more patients tend to have radiation. But that's not etched in stone. So let's dive into these a little bit more. I'm going to do radiation quickly first, and then I'm going to dive a little bit more into surgery since I know so much about that. So everyone always asks, because frankly, because it's marketed like crazy. So we talked about internal radiation, let's call that brachytherapy or SEEF, but now we're talking, and even CyberKnife is external beam radiation. But let's just call it, this is the category of external beam radiation. The machines have evolved, and generally, the better the machines, the higher the dose that can be given. The higher the dose, the better the cure rates. Nothing ever will surpass the cure rates of surgery in experienced hands, frankly. But as I said, radiation, the field of radiation is very scientific, and they're constantly doing things by changing technology and adding hormone therapy, frankly, to the radiation therapy to improve their outcomes. Okay, so if you're considering radiation, people are going to ask me about proton beam, which is just an energy source, and IMRT, which is, I can't remember, frankly, I think it's neutrons, could be electrons, can't remember, I think it's neutrons. IMRT means intensity modulated radiation or 3D conformal. These are different technologies that are advanced technologies to have the beams conform and overlap on the prostate. And I've seen plenty of lectures here. Really, there's nothing saying proton is better than those other things. There's this feeling that proton may, with future trials, be shown to potentially be more focused to be able to increase the dose. But really, right now, it's more of a marketing thing, if you ask me. Maybe in the future, there'll be some proof. So if your local radiation therapist doesn't have proton beam, that is not the end of the world. The key to understand, though, now, with radiation, though, is that they're going to give you hormone therapy. The risk stratification is going to matter a lot. It doesn't make much difference with surgery once the decision is made, but it makes a lot of difference in the radiation world because it tends to dictate the protocol that's used for your radiation therapy. And it's a shifting goalpost situation. Generally, the more studies that occur, and I just read this very long review article on this, so it was interesting to see where these conclusions came from. But there were several papers that came out actually using medicines that we don't really use now. So whether that can be truly extrapolated, who knows, that suggested that if you give a man hormone therapy, either during his radiation and after, or a couple months before and then after, that down the line, patients tended to do better. There were more cures. And generally, every time a new study has tested a longer duration of hormone therapy, it's come up with slightly better cure rates. And it's not a huge difference, but it is a statistically significant difference. But the hormone therapy does come at a big cost. I generally, when I'm talking to patients, there was the day where they didn't give hormone therapy, or at least in the moderate risk department, they didn't give hormone therapy. And in that day, I used to always say, between surgery and radiation, it's pick your poison. They both have glasses of poison in front of you, and they're at about the same level, meaning they're different side effects. But I'd say the poison is different flavors, but it's the same amount, different side effects, but same overall hassle to you. But the problem now is with the addition of hormone therapy, and sometimes they'll still give you 6 months if it's moderate risk, but if it's anything a little higher than moderate risk, these days it's around 2 years. I actually just talked to a radiation therapist who says there's a new paper that suggests 3 years. It's very controversial to me because it comes as a big lifestyle expense. I'm not sure I would do it for 2 extra or 4 extra percentage points of cure. I'm not sure I would do 2 years of hormone therapy. I just had this discussion with a patient of mine who is a big athlete and lifts weights all the time. He's got to give up his life to do that for a theoretical benefit of a few percentage points. So again, you really want to dive into that. I know by giving hormone therapy, and generally hormone therapy is used for cancer that has spread, so that's a different discussion. But we urologists know that commonly, if you give hormone therapy for a significant period of time, it takes a very long time for your testicles to wake up and make testosterone again. Hormone therapy is the act of giving drugs that make you make no testosterone. And I'm assuming that a lot of the improvements that they see with radiation plus hormone therapy is just that some men are on permanent hormone therapy and their testicles don't wake up. So that's a discussion we can have if someone's considering external beam. And I always ask them to ask the radiotherapist, what protocol of hormones will you be using? How long will it be? Because that ought to weigh one's opinion between surgery and radiation. The cup is bigger now, therefore, with radiation than surgery in all categories. There's more side effects when you add the ones of hormone therapy, but they're going to do that to get their cure rates up. And what are the side effects of radiation? Well, early on, oh, I have a typo here. Early on, there's bowel and bladder irritation. So I have to poop a lot and I have to pee a lot. And at the end of the course, not in the very beginning, you tend to get very fatigued just because your body's, helping itself from the damage to the tissue. Now, the mid-range side effects, so this is getting us to maybe a year or two later, it tends to cause the blood vessels to your tissue to sclerose. So that lends itself to scarring. And when your bladder neck scars and it won't close down, which is the bottom of your bladder, that's incontinence. That's not, that's about the same risk of incontinence permanently with surgery. We'll talk about that. Not high, 3 to 4%, but when it does happen, it's harder to treat. And of course, we have to talk about erectile dysfunction. Before there was hormone therapy, and I'm going to show you a curve later when I talk about erections after surgery, but people will generally, I find that the average person will talk to the surgeon first because they biopsied you. The surgeon should be very honest about the effects that are going to happen with erections. They see the radiation therapist and they say, am I going to lose my erections right away? And the answer is no. But actually, I'm going to talk about it when I show you this graph. But the thing about radiation without hormones is that your erections will be fine, but then at about 9 months, they're going to start going downhill and they'll keep going downhill. And that has to do with the sclerotic effects on blood flow, because that's what controls erections. So if you're really looking, and there were many head-to-head studies a long time ago between open surgery and radiation, what they would find, and you're going to see with surgery, that you lose your erections, but that you hope that they return. And that with surgery, it's the inverse. You're okay at first, and then it gets worse and worse. So the curves always cross. The surgery people are better in the long term with their erections than the radiation people who are better in the very short term. So if you're older and you still have erections, which most don't, they may say, that's a big deal to me. I may as well hold on to my erections for the next year, year and a half, et cetera. So those are the mid-range effects. But then there's even late effects. Something called radiation cystitis, where your bladder will start bleeding because it's cracking, like chapped lips. And there's a risk of secondary malignancy. Anyone who's been a busy urologist and treated a lot of prostate cancer will definitely see more cancer in their radiated patients. Hard to prove, certainly an impression that there is a secondary malignancy risk, which of course there is, it's radiation. So those are the downsides, but the upsides of surgery to patients, usually, if they're thinking about this, is it's not surgery. And that's what's going for radiation. But these are things that most patients who have discussed radiation, they don't know the granularity of it. And if you ask them about the side effects, they generally can't quote these to you after that discussion. It tends to be less in detail. I think the discussion with a surgeon tends to be in more detail, because it's the surgeon's doing it to you. My hands are doing it to you. So I need you to know what's going to happen here. And I think that a lot of that, it's not that the radiation therapist is glossing it over. It's just the patient tends to come at it from a different mindset. So if I have a patient that's choosing radiation, I am 1,000% okay with that, as long as they understand the pros and cons. And then we'll talk about prostatectomy. Again, it's really robotic prostatectomy, and came out around 2003. And it's on my website. I haven't gotten to this part of doing the robotic surgery section, but just suffice it to say that surgery used to be through an incision under your scrotum, and then it was done through an incision in your lower abdomen, and then it was done for a little while called laparoscopically, but it was too difficult for the average surgeon to pick up. And then this tools called robotic instruments came out, which transformed really all of surgery, but particularly urology, because it allows you to do surgery through scopes, but the tips of the instruments move like hands. So now it's perfect for operating in a small space. By the way, I'm gonna take a second here. I'm going to see later, and I'll get help with this if it's not working, but I'm going to want a lot of questions at the end of this. I'm not looking to see what they are right now, but if you have them, keep them in mind, ask them at the end, please. And I'm going to answer all the questions that I get, and it's be hard to believe that there'd be no questions. So we'll see how it goes. So it's an overnight stay in the hospital. So I did 2 of these on Wednesday. Both of those patients have gone home already. I think both of them would say they're not in much pain. They're just a little bit sore. Half the patients don't take pain medicines when they go home. They're given non-narcotic medications in the hospital by me. There will be a catheter that they go home with. So they have to, heal over that catheter. The act of a prostatectomy, the removal of the prostate is detaching it from the bladder and severing the urethra and then reconnecting the bladder to the urethra. With that, by the way, you have to take out the structures that make semen. So, you don't lose ejaculation, but you do lose semen. You tend to lose it with radiation for different reasons. So these men will feel better each day. These men are already up and walking around in the hospital. These men who had their prostates done on Wednesday will see me on Tuesday, and they'll get their catheters out, and they'll look really good on that day. And I always tell patients that within 2 weeks, you're going to feel like nothing happened. Okay. Many people go back to work sooner than 2 weeks. So that's a high bar saying you'll feel like nothing happened. But it is a very rapid recovery, and that's because of the fact that we're doing it in a minimally invasive way called robotic surgery. But what will not be recovered, and what is the true recovery of surgery, is incontinence. So everyone is going to leak, and I make a big point of this. Everyone's going to leak. It's not, I never say you may leak. That's, if you see that on a website, they're really just not being honest with you. Okay. Looks like there's some typos here. I didn't fix this either. So that's a plug for my other talk on my website. But incontinence is something that you have to understand. That's not a complication. That is what's going to happen after surgery. That is the recovery. You have your ACL done in your knee. You're going to have to stretch it out. You're going to have to go through a period of time of working that knee. You're going to have to go through a period where you wear pads, and it's very variable. It tends to be something that people get used to very quickly. It tends to be something that almost always resolves. There is a certain percent of patients that will leak to some degree. And any degree to me that where you still have to wear pads is too much as far as I'm concerned. It's very much something I don't sweep under the rug. I will ask patients about that every time they come in. I want to see how much you leak. You can't tell if they would say they wear one pad all day, because sometimes they're just doing that for confidence, but it's very fixable. So it's very variable. There's a certain percentage that it'll be permanent at 1 year to some degree, about the same with incontinence. But unlike, with radiation, but unlike radiation, it's very fixable. So that's on my website too, if you have any interest in learning the procedures that we do for that. But generally, when I see patients at the 2 to 3 month point, they're good. Are there some patients that dry up after a week? Yes, I never talk about them because it's not a good expectation to have. Better to have an average expectation. Are there patients that take longer than 2 to 3 months? Yes, there's certain people I can predict that will happen. Anyone that didn't have a perfectly smooth surgical recovery, it tends to happen. But the good news is incontinence just tends to be a transient thing. The big issue and the uphill battle tends to be erections. That's why I put it in bold, and that's why I'm going to talk about it more. So far, if I tell a patient, look, we're going to have surgery, you're going to go home the next day, there's not going to be much pain. I've done over 3,000 of them. I know what I'm doing. You got a catheter, but it's really no big deal, and you'll feel like nothing happened at 2 weeks. Sounds great. Even when I say you're going to leak some, but no one's going to know, it's going to be like a woman with a maxi pad. It'll get better and better, and we'll teach you what you can do to help that. Generally, everyone's going to sign up for surgery at that point. But when you say, and if you have to say, if you're being very honest, but when you say, but you're going to lose your erections, 100%, you're going to lose your erections in the beginning. And that's been a message that I have had from day one. Way too much marketing has happened in the prostatectomy world. A lot it was just a heyday of marketing back in the days when PSA first came out. A lot of the academic institutions around here were really fomenting the idea that it's all about the nerves and sparing the nerves. If you come to us, we'll spare your nerves, and we have your salvation at our fingertips. And really that just wasn't the case. Everyone, doesn't matter who did the prostatectomy, loses their erections in the beginning. What I'm going to show you is what I call the curve. And I was really known for this message from day one. I've been in the New York Times several times. I was known as the honest guy. But that's a part of the recovery. And if I'm counseling someone about this, I have to take it head on. I know that most men, by the time they're having a prostatectomy, have trouble with their erections. You can look at, watch one of my erectile dysfunction talks, and you'll see what I'm talking about. I know that many people that have been married a long time, that's just not going to be a big interest to that couple, particularly to the woman in that couple. And so I tend to have a pretty detailed discussion because I want it to be an open discussion so that I'm very clear on what I can do to help patients. But it's not to say that it's hopeless, but it is to say that it always happens. And there used to be a day where everyone was all about talking about nerve sparing because it was the Johns Hopkins Pat Walsh nerve sparing operation. And it was like thought of, if you spare my nerves, I'll get my erections. And with the advent of robotic surgery, I spare your nerves perfectly and you will lose your erections. So the minute you started having robotic surgeons talk about erections, we don't talk about it as a nerve problem anymore. We talk about it as a blood flow problem. And it makes perfect sense because if you look at big, huge studies, and this was really the crux of all my research and outcomes data, and if you go to my bibliography, you can read some of my papers. The return of erectile dysfunction after prostatectomy, okay, almost has nothing to do. I should have put on here, surgeon skill, but I would have put it last. It would have everything to do with how good were your erections beforehand, which really means how good is your preoperative blood flow, which sort of correlates with age, but you can be out of shape and not doing so good in the blood flow department at a younger age. You can be older and have excellent blood flow. I try to have really good blood flow. I work out a lot. And so this has everything to do with, are you going to get them back? And so does this. How interested are you? You got to be interested. And more importantly, you have to stay interested. You can't afterwards just feel sorry for yourself and so woe is me. You have to know what to expect. And you have to know what success looks like, actually. And then huge is their partner interest. And so, the usual man being the aggressor in the relationship, or, even in a gay couple, one or the other can be the aggressor, and that's just how it works. And that happens that way. Those roles have to be reversed a little. There has to be a bit of an honest discussion because the man after prostatectomy is going to have to work on this, and the man after prostatectomy is not, can't get embarrassed. And so these are the types of talks I have with patients about this. Patients think that what I mean is yeah, but I'll give you Viagra and everything will be okay. Not true. I'll talk about that when I show you the curve. And every patient who's looking at a prostatectomy, I can again see there's a typo here because I'm missing a thing, is the role of shots. And what are shots? Shots are injections that men use with medicine that dilates arteries into their penis. And that's really what every man does, aside from prostatectomy, if they have problems with their erections. It starts with the problem, then it starts with pills, and then pills eventually don't work. That's what everyone does in our society. It's not weird, but it's something I bring up to patients because I want them to do shots, because I want them to stay interested. Shots work right away, and they work almost every time. And to me, that's the most healthy thing to do. There is a concept called penile rehabilitation. Some people still tell their patients to take Cialis 3 times a week or Viagra every day after surgery. That's that concept that if you take medicines like that every day, it'll rehabilitate you. And that's a concept that was very much disproven, including the landmark article that I was senior author on in the Journal of Urology, where we tested that hypothesis and it doesn't work. So that's why I don't bother with that. I tell them, man, if you're interested, trust me, do shots, because then you're in the game. And the role of the shots also is so the man knows he could do it, even if he's not doing it. It makes a big difference mentally. And this is that curve that I've been talking about. So I call this the curve. And this is a curve that back when I would be at the meetings in the small little rooms, and I was the only surgeon with impedance researchers. So it would be, the impedance researcher from NYU or Sloan Kettering or UCLA, or big programs where they were doing many prostatectomies. All of the curves looked identical. You couldn't tell. The only way they'd look a little different is if you were comparing robotic surgery to open surgery. But other than that, the big secret was everyone that was good at it had the same exact curve. And no one has ever published this in America, basically. I wrote an editorial in a European journal, Nature Reviews, where they did show this. A European group showed this because they're not marketing. And I was saying kudos, and I admitted this is exactly what my curve looks like. So this has been on my website from day one. It's something like cases number 200 to 500 or something like that. So because I don't think I'm learning much after case 500. So what does it show? Let's not worry about what this is, but it's a questionnaire that is way more than just asking, do you get good erections? Because it doesn't mean anything. If you have, the men that you put in a study like this, because you want them to succeed, start with a perfect score. They get perfect erections. Nothing wrong with their erections. And all of them are thinking, well, you're telling me that guy's going to lose his erections, but I'm not losing my erections because I am the man here. And the answer is they're going to lose their erections. So this is right after surgery, and 6 means you get nothing, and 30 means it's perfect. And notice at 3 months, it's nothing. So when I see patients, I'm showing them their PSA is 0 and they're cured. I'm hoping that they're out of pads. I'm not even asking if they have erections at 3 months. But at 6 months, some people will start to say, you know what? I'm getting a little bit of fullness here. I don't get an erection, but something's starting to happen. If they don't understand this curve, they're not going to understand that's what success looks like. So the man that thinks he went somewhere and he's going to get his erections back is going to be depressed that all he gets is that little fullness. The man that my patient's going to understand he's right on the right track. And I'm hoping he's using injections to succeed along the way. At 9 months, there'd be some more fullness. And at 12 months in any of these studies, you had to do it for at least 12 months in the hopes that some of the men, half the men, could say, hey, for the first time, I was able to have intercourse with my partner. So notice that at 1 year, it's not even close to where we started, but it's about 17 that you be able to get it done. And then notice it keeps getting better. So you remember I talked about that curve with surgery where it's bad, but then it just keeps going, and it'll get better even beyond 2 years. Radiation would look like this. It would go and then just start going down, 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 and then it would just keep going down. So that's what I was talking about. So the key is these men have not gotten back to where they originally started. But the number one key is these men are taking Viagra like crazy. This is a perfect guy with good blood flow on Viagra. That's the key, which means it does not work in the first year. It's only going to work for the guy that says, I'm close, I'm getting a semi, I'm close. And that's what I talk to patients about every 3 months. And when I think they're close, that's when we try to switch to pills. So that's the curve. That's a very honest assessment of what to expect. Not hopeless, probably will get them back, but it's going to take a long time. That's the bottom line. Okay. So going back to the chart, we would have known, should we be treated? We would have gotten a little bit of a sense, or are we comfortable, or are we a perfect patient for one of these lesser cure rate treatments? But if we say, no, we got to go back on the rails and develop a leaning here, then it's a leaning between surgery and radiation. Okay. And whether that be IMRT or proton and what length of hormone therapy, that oftentimes is best done and best figured with personality. When do I very strongly recommend surgery? I already told you, in the high risk group. And why do I do that? For the following reason. Well, the number one reason is because it allows you to tailor therapy. If you have radiation, you can't have surgery after radiation, really. But you can have radiation after surgery. So if you do surgery, your PSA goes to 0, even if you're high risk. And I wrote a pretty landmark paper. These are the 2 papers I'm kind of most proud of, so I'm mentioning it. Very, very big paper on high risk prostate cancer. You'll know what your lymph nodes were. You'll know, are you cured or not? You'll know what you actually had in your prostate. And that very much allows you to know, do I need to add more treatment, or am I okay with the amount of treatment that I've had? So I like that tailorability. Patients like to know if they're cured or not. Whereas with radiation these days, if you're high risk, the entire kitchen sink is thrown at you. You're going to get the longest course, the highest dose, and the highest length of hormone therapy. So there's not a tailorability, and in most cases, you simply won't know if it worked for 3 years until the hormone therapy wears off. So to me, there's every reason to think about surgery in the high risk group. So if you're comfortable and you're a good candidate for radiation, you have the radiation. And then the last thing just to bring up, and I just embrace this fully, I fully embrace this, is it's because of where we live. We live in a very metropolitan area. A lot of people feel like they can go anywhere they want to go. If I lived in New York, people would think maybe I need to go to Sloan Kettering. Around here, they tend to say I need to go to Johns Hopkins. If you're in Richmond, they might say I need to go to University of Virginia. So this spring comes up no matter what. If someone says I want to have surgery, then they have to say, you know, who do I want to do my surgery? And what I find is it's either I want I want an institution to do my surgery, so you can fill in the blank, or I want this particular surgeon to do the surgery. So obviously, if it's me, you're asking me to do it, which means you're going to want me to help you with your erections. You'll need to feel that I'm the best to help you with all of those other things. And if someone says I'm not comfortable with that, it tends to be a socioeconomic decision too. And I need to go to Johns Hopkins, or I need to go to MD Anderson, then that is where they need to go. That is and I strongly support it. I ask people, just give me an idea, and I will tell you who I would have operate on me at those institutions. It's not everybody. So that's what this is. And I ask people to be honest so I can guide them and at least have them see the right person. If they choose me, then the idea is it's at that point we generally have a much more detailed discussion about surgery. We're going to talk about that curve. We're going to talk about what to expect about leaking, and step by step by step by step by step. And so we've talked for a good long while here. I'm hoping some people stick around with questions. I'm going to make sure the chat room works. But these are some final thoughts that I didn't really represent on the slides. And that is, again, in a nutshell, don't start looking at treatments. If I tell you or anyone tells you you have prostate cancer, just start reading about the problem. That's why I split it into 2 essays on my site. Understand what it is, understand your case, and understand, do I even need to be treated before you look at treatments? Okay? It's like shopping for a car. Don't just walk into the dealer first, do a little research first so you know what you're looking for. Feel very comfortable as to whether you need to be treated or not. Don't have buyer's remorse about that. Know what treatments, therefore, are appropriate for your case, and don't just pick what sounds the easiest or the best. And really get some introspection. Don't try to figure it out scientifically. Just learn about all of them and match your personality with the treatment. And then this goes for who you have radiation with, but it specifically goes to who you have surgery with. I call that, and I very much used to call that, assignment of credibility, meaning the person you want to do your surgery, and I personally think you should demand a person who not only will do your surgery, but it's going to be the one that treats you for the side effects, because no one is going to treat and help your side effects more than the person that did it to you. That's just a side recommendation. It's something I've always prided myself on, that I expect my patients to come back to me so that I can help them. but assign credibility to the surgeon. If that person has to, be in a certain institution, then that's where it has to be. And then once you assign that credibility and say, that's who gives me confidence, then just do whatever they tell you to do would be my recommendation. Because you don't want to have ever buyer's remorse. You want to understand each decision you've made. And then no matter what happens, you'll say, I did the right thing. I had to be treated or not. And I went to the best person. And so the rest of it is up to fate, God, chance, however you view that. That's my recommendation too. So I'm going to look at this to see how we're doing in terms of that. I think the chat box should work. It's completely anonymous, by the way. I need you to know that. No one will see your questions. I'm hoping to click on this chat box and see your questions. I really urge everybody to go to my website here. And if you haven't watched this or couldn't watch it, or you have someone who wants to watch it or might be help, it should be up on the site within a week or so on the front page under the lectures. And make an appointment with me. Let's talk some more if you want to. Let me click on the chat box and see this. Okay. So let's see. Okay. I just got a question, so I at least know it works. I don't have a lot of questions, so we may not get a lot of questions. But fire away if you can. But I'm going to start answering some questions that I see here. Do penile shots work with a patient who has had radiation therapy and starts to lose his erections? Absolutely. Shots will work for practically everybody. You might need a little bit of a higher dose with radiation therapy, but that's definitely the way to go if pills are not working. And someone has asked me to expand a little bit on cryotherapy, cryosurgery. It's not really surgery, so we call it cryotherapy. Cryotherapy has been around for a very long time. And since it was a new technology and it wasn't really surgery, it really had to prove itself. And what is it? It's very similar to seeds in that you're asleep. We put needles in your prostate through an array that's underneath your scrotum. Seeds, we would implant pellets that way, but here we're putting special needles, measuring where they are so they all kind of create a ball of ice, and you can imagine a bunch of circles expanding and they're going to coalesce, and we can control that freeze. We can turn it on or off. So it's very much under control under an ultrasound. We don't want the ice to go and hurt your rectum, just like we wouldn't want radiation to hurt your rectum. And so in that circumstance, it's a one-shot deal. You do have a catheter in. It's a little harder to urinate in the beginning. And it takes about, the PSA starts to go down. It might take 3 or 6 months to go down to where it should. It doesn't always go to undetectable. As long as it goes to a very low level, it's fine. The risks are kind of similar to the risks of radiation, which would be very rare. I had never seen it actually, an injury to your rectum. Actually, I had one patient who had hernia mesh, and the mesh was touching his prostate, and so that created some scarring. But otherwise, it's very well tolerated, and it can be repeated, as I said. Tends to be for older patients, though, because it's going to take your erections away. My impression is that your erections come back similarly to the curve I showed you, but probably not as well as surgery, to be honest with you. So, again, better for the older patient that doesn't get good erections, that has trouble urinating. Let's see. All right. Okay. Now, I'm not getting many questions, but I just got another one. So again, if anyone's still there, fire away. And as they come, I'll take care of it. So I'm going to read this one out loud. This person has been taking finasteride and their PSA numbers have gone down, which of course, in a benign setting, finasteride should make your PSAs go down by 50%. Okay. So, and it says this patient's been monitoring the PSA since 2008. His urologist said he should have surgery. So he's not really talking too much about what a biopsy showed. And a radiation person said radiate, and then saw another doctor at Mass General in Boston, and he said monitoring, which I suspect means active surveillance. And so here's a patient who I think I'm not going to name any names, but this is a very typical situation where I think in this case, the finasteride, we can talk about that in a minute, but it's kind of neither here nor there. But the finasteride, it's not really a prostate cancer treatment, but what I think is a good example here is this person has gotten 3 different opinions. So here's one person says surgery, and they're going to say that's just the knife happy surgeon because it's the urologist, and the radiation person says radiate. It's one of the reasons I love Sean Collins here at Georgetown. He won't always say radiate. It's hard to find a radiation therapist that will tell you, look, I think you ought to have surgery. They're pretty rare. And then the other person said do active surveillance. Personally, I find myself being in that Mass General situation most commonly. And if someone said you're a good candidate for monitoring, meaning active surveillance, you probably are. And there's no downside to doing it. Worst case scenario, your PSA will rise later. You'll get a biopsy, and then you'll know for sure you had to be treated rather than potentially being overtreated. So happy to talk to you and give you my opinion if you want to, but that's a very common situation. And it would be very hard for a patient to know what to do there. But this patient went to someone at Mass General, and they usually assign credibility to that person. And so if that's the person that gave you the most peace of mind, then that's the instruction you should follow. That's really what I was talking about in that journey in a nutshell. Taking the finasteride is perfectly fine. I would stay on that finasteride because I'd want to keep the conditions the same so that I could interpret what happens to the PSA moving forward. Hope I answered that question. Another question here says, follow-up on this person's path report is Gleason 3+3 and only 1 needle shows cancer. I hope that you know what I'd say. I don't know what your PSA was, but that's just, we're going to call that insignificant cancer. I can't imagine. The last person I offered surgery to with 1 needle positive with the lowest Gleason score had to be 15 years ago. So without knowing the details, I'm going with the Mass General person on that. That's a perfect example of how if you don't know, you could be overtreated. Another question, what is I think you need to say IIF score for someone who did not have a prostate cancer and therefore did not have surgery? And what was the age grade of the patient group represented on my graph? So what's an IIF score? It's an International Index of Erectile Function. So we can talk about that a little bit. In the beginning of the heyday of prostatectomy, which is really in the 90s, it's because PSA was invented and popularized in the early to mid 90s. So there was this huge rash. There'd been a new way to do surgery at Hopkins. It was called the Pat Walsh nerve-sparing prostatectomy. And Pat Walsh's definition, and he said, look at my potency rates. But the definition of potency was he would sit at the desk and ask you, could you take your penis with your hand and stuff it into a vagina? It had nothing to do with, were you happy with that or were you depressed about that? Could you have sex to the point where you could finish? So it was really a completely worthless parameter, especially when you're trying to please this person who told you he's going to help you. It's the most non-scientific way to do that. So the IIF score was created and super validated with very tough questions. And it was 5 questions or longer, but it tended to be condensed to 6 questions, actually. And there were more questions more like, were you very happy with your erection? Could you finish? Was your partner satisfied with your erection? So the much higher bar than that. And that's really when the study of erectile function started to become more honest and started to become less marketing and more objectified. And robotic surgery was newer, and we had to prove ourselves compared to that kind of salesmanship with open surgery. And so we would always, and you would never get a paper published 2010 or beyond, if you didn't have not only the IIF, but something called a SHIN score, you had to have these validated scores that were very reproducible. So you knew exactly what that meant. So, it was like the answer was 1 through 6. So if you had a 30, you had 6s down the line. And if you had a 6, you had 1s down the line. So that's what that is. It's not specific to prostate cancer at all. So that would be how you would get FDA approval, for instance, for a new drug. And the age range in that group, I'd have to say off the top of my head. Now, generally, you'd be doing surgery on younger people, but I can tell you that the age range would have been relatively young because not many men, once they get into their mid-60s, are going to have an IIF score of 30. That would be a Superman. And there'd be a fair amount of picking and choosing who you want to put in your study because you want to look good. So I would estimate that the average age range in that graph was probably 56, right where I am. And in good shape and interested. Okay. So those are great questions that would allow me actually to kind of go off on some tangents that I think were very, very helpful. I don't see any more questions. I'll just wait a few more seconds just to make sure I'm not answering. Okay, here's another one. And it's over. So I'll read it. And my questions are my favorite part, so please don't feel like you're imposing upon me. It says, I just lost a friend to prostate cancer. Sorry to hear that. Who was optimistic about his survival after he spoke with friends whose doctors found more cancer in them who had cryosurgery. Friend was eager to have the catheter removed, so maybe this means this patient had cryosurgery. And the doctor agreed to do so he could go to a New Year's Eve celebration. And he traveled from Florida by car, and then a week later, when he got back to Florida, died. So it's not clear what that was all about. But this actually, all right, so I'll just keep reading it, but I think it demonstrates a point. So they don't really know what happened to this patient, and we're talking about something called a TURP, which is an operation to help you urinate, and cryosurgery. So actually, I don't know what to say about the friend because I don't really know the details here, but I can say that this illustrates a very common phenomenon that I see. What in this question, we're mingling two different problems here worth talking about. There's prostate cancer and there's BPH. Again, separate problem, have a talk on my website about it. BPH is just the natural enlargement of a man's prostate as he gets older, and it's hard to urinate. So that's called prostate enlargement, but that's not from cancer. So the enlargement wouldn't be from cancer. So most people don't understand that you can have an enlarged prostate and have cancer in it, but it's not the cancer that's creating the enlargement. So that friend, who knows if he needed a TURP, but a TURP would not have been a treatment for cancer. It would have been a treatment to help him urinate. And then cryotherapy would have been from something else. Sounds like he died from something other than prostate cancer, if he died that quickly, to be honest with you. So, okay, so now we're at the point where okay, just getting some thank you notes here. And yeah, go ahead and share the link. My website gets about 40,000 hits a month, I'm told. So I know that a lot of people are watching my lectures that are not going to see me, and they're not going to come to me because they're not in town here. And I think that's great. So if there are no other questions, I'll go ahead and I will probably end this if I can figure out how to end it. Thanks so much for attending. I'll go ahead and get this up on my site, and hope to see you soon. Hopefully not for prostate cancer. And if so, I'm happy to help you. See y'all later.